Welcome back to the deep dive. You know the drill here. We take your source material, your notes, whatever you've got, and really dig into it to pull out the crucial bits fast. No waffle, just the good stuff.
Exactly. Straight to the point.
And today we're diving into something specific you sent over, your revision notes on otosclerosis. So our mission basically is to go through these notes section by section and just, highlight what you absolutely need to know, make it stick.
Sounds good. And otosclerosis, just as a top line from these notes, it's essentially about abnormal bone growth in the ear. And that growth really affects how hearing works, which is exactly why, getting a solid understanding is pretty vital for anyone studying this.
Totally. So think of this as your guided tour through your notes. We'll hit everything, what it is, the why, the who, how it actually affects hearing, how we investigate and treat it, and the outlook. Let's jump in. Okay, first things first, let's tackle the definitions section in your notes. What exactly is otosclerosis?
Right, so the notes define it as a progressive condition. And that progressive word is really key here. It tends to get worse over time. It involves this, abnormal bone growth, mainly happening in the middle ear. And it particularly likes to fixate the stapes bone.
The stapes, one of those tiny little hearing bones.
That's the one. So this leads to what's called stapes fixation. The stapes is meant to vibrate, pass sound along. If it gets fixed, stuck, sound transmission gets blocked. Your notes also mention it's sometimes called otospongiosis that reflects an earlier, sort of more active phase of the bone changes. And importantly, they really flag the genetic link, often autosomal dominant inheritance.
Ah, okay. So genetics are a big player.
Definitely. The notes describe it as a kind of metabolic dysplasia, basically. Abnormal tissue development affecting the otic capsule, the bone surrounding the inner ear. And those little ossicles, the ear bones, this weird bone turnover messes up how sound gets conducted, leading to conductive hearing loss. But the notes also point out if that growth creeps into the inner ear, the cochlea, then you can get a mixed loss, both conductive and sensorineural.
Got it. So the core idea, progressive bone issue, middle ear, sticks the stapes, blocks sound conduction, simple memory trick maybe, auto for ear, otos for bone, sclerosis for abnormal hardening, abnormal ear bone growth. That kind of works.
Yeah, that's a good way to think about it. It's about the bone hardening or growing abnormally where it shouldn't.
Okay, so if that's what it is, the obvious next question is why? Etiology. What do your notes say about the causes?
Well, the note's pretty clear that the exact cause is complex. It's not fully nailed down. But they really hammer home that genetic factor we just mentioned. Autosomal dominant inheritance comes up again as a major player. A family history definitely increases risk.
Right.
But it's not just genetics. The notes also list environmental factors. Hormonal influences, for example, with pregnancy, sometimes seeming to, trigger or worsen it. And there's also mention of viral infections. Measles, specifically, has been looked at as a possible contributor.
Measles. Interesting.
Yeah, though the notes present it as a complex interplay. Not just one thing, but maybe your genetic susceptibility meeting one of these triggers.
Makes sense. It's rarely a single smoking gun for these things, is it? More like a combination. So for revision, remember,
Yeah,
genes plus environment like hormones, maybe past infections.
precisely. That interaction is key.
All right, moving on to risk factors. Who typically gets this, according to your notes?
Okay, the notes lay out the classic risk factors pretty clearly. First, race. It's noted as being more common in white and Asian populations.
Okay.
Then sex, it's more common in women. Age is also a big one. Symptoms usually start showing up between 15 and 35 years old. Though the notes mention the overall prevalence age range might stretch a bit wider, maybe 15 to 45.
15 to 35 or 45. Young to middle-aged adults, essentially.
Exactly. And no surprise given the genetics, a positive family history is a strong risk factor listed. Your notes also have this slightly interesting point about non-fluoridated water, but they do add the caveat that the studies on this are inconclusive. So it's mentioned, but maybe not as solid as the others.
Right, so stick to the big ones for revision. Family history, female sex, that 15-45 age bracket, and Caucasian or Asian background. Maybe that FAR mnemonic helps. Family, age, race, sex, if you see that demographic in a question.
Otosclerosis should definitely be high on your list, yeah.
Okay, let's get into the mechanics. Pathophysiology. How does this dodgy bone actually cause the hearing loss? What do the notes say?
So the notes really focus on this abnormal bone growth and remodeling process happening right around the stapes bone. And the crucial outcome is stapes fixation. Normally, sound hits the eardrum, vibrates the little bones, malleus and submucous stapes. The stapes footplate then pushes into the oval window of the inner ear, creating waves in the cochlear fluid. That's hearing. But if the stapes is fixed, stuck fast by this extra bone, it just can't move properly. It can't push effectively into the inner ear. The vibrations get dampened or stopped.
Right, like that rusty hinge idea. The hinge on the door to the inner ear is seized up, sound can't get through properly, it's a mechanical block.
Precisely. It's that physical interference with sound transmission that causes the conductive hearing loss. The notes are very clear it's a mechanical problem.
Makes sense. Now, your notes also list differential diagnoses, other conditions that might mimic otosclerosis. This is super important clinically, right? How do we tell them apart based on these notes?
Absolutely vital. You need to distinguish it from other causes of conductive or mixed hearing loss. The notes state pretty clearly that the key tools for differentiating are audiologic tests and imaging.
Okay, so tests are key. What's on the list of lookalikes?
Well, things like chronic ear infections, chronic suppurative or chronic serous otitis media, like long-term glue ear, those are infection or fluid problems, generally visible. Damage to the other ossicles, like the incudus, maybe from past infection or injury. Congenital stapes fixation is another born with a fixed stapes. But your notes crucially add that this is usually non-progressive, unlike otosclerosis, which gets worse.
Ah, that's a key difference, progressive versus non-progressive.
Exactly. Meniere's disease is mentioned, but usually only if dizziness is a really big feature, which isn't typical for primary otosclerosis. Then there's post-infective tympanosclerosis, scarring after infections, Paget's disease of bone, osteogenesis imperfecta. But these often have other signs, like osteogenesis imperfecta might have the blue sclerae, the brittle bones. The notes imply these are usually distinguishable.
So while the symptom might just be hearing loss, the specific test results and maybe imaging patterns are what point towards otosclerosis.
That's the gist of it, yes. The audiometry patterns, the tympanometry, maybe the CT findings help single it out.
Right. Good revision point. Think about a patient with progressive hearing loss. What else could it be? And what test helps narrow it down, according to these notes? Working through that helps lock it in.
Definitely.
Okay, let's talk numbers. Epidemiology. How common is this condition? Your notes mention UK figures.
Yeah, they give a couple of useful stats. Histological prevalence, meaning the bone changes are there if you looked under a microscope, even without symptoms, is around 2.5%. But clinical otosclerosis, where it's actually causing hearing loss and symptoms, is lower, around 0.3%.
0.3%, okay.
And the estimated UK prevalence is quoted as about 1 in 200 people. So, not incredibly rare. You're likely to encounter it.
1 in 200. That's a
Yeah.
good ballpark figure to have.
Yep. And the notes just reiterate those demographics, 15-45 years, more women, more Caucasians. And that interesting point, again, about maybe a decreasing annual incidence, potentially linked to measles vaccination.
That measles link keeps popping up. It's a really interesting thread in these notes. Okay, 1 in 200 clinically. Got it. So what would the patient actually tell you, and what might you find? Clinical features, signs, and symptoms from the notes.
Okay, symptom-wise, the big one listed is progressive hearing loss. Often starts with the low tones, low frequencies. Tinnitus is very common too, that ringing or buzzing, and often a feeling of fullness or a blocked ear. Onset is typically in that 20-40 age range. And the notes do mention that dizziness or balance issues can sometimes occur, though it's not the main thing usually.
Right, and what about signs? Things you'd observe?
Well, one interesting sign is that patients often speak quietly because their own voice sounds louder to them due to the conductive loss. It's called autophony. They subconsciously lower their volume.
Ah, okay. Makes sense.
And crucially, on oroscopy, looking in the eardrum typically looks normal. That's a really key finding. No signs of infection, fluid, perforation usually. There is that specific sign, Schwartz sign, mentioned that reddish glow behind the eardrum from increased blood flow. But your notes say it's only seen in about 10% of cases. So nice if you see it, but you usually won't.
Okay, so don't hang your hat on the short side.
Exactly. And then the hearing tests will show that typical pattern. Conductive loss, worse for low tones initially, possibly becoming mixed later.
So classic picture from the notes. Progressive low tone loss, youngish adult, tinnitus, normal eardrum. That normal look is key.
That's the pattern to look for, yes.
Okay. We suspect it. How do we confirm it? Investigations. What do your notes say we need to do?
Right. It's very direct here. The number one primary investigation is audiometry, the formal hearing test. It measures both air conduction sound traveling the normal way and bone conduction, bypassing the middle ear. And in otosclerosis, you expect to see that gap, the conductive loss, especially in the low frequencies, or a mixed loss if it's progressed.
And it mentions specific audiogram features.
Yes, Carhart's notch is highlighted a specific dip in the bone conduction line, usually around 2 kilohertz. Seeing that is quite suggestive. and maybe excessive sensorineural loss for their age if the cochlea's involved.
Okay, Carhart's notch. Good one to remember. What else?
Tympanometry. This test checks how well the eardrum and middle ear system move. Your notes say in otosclerosis, you might get a stiffness curve, basically showing reduced compliance, reduced movement, because that states is fixed.
Stiff system. Makes sense. Imaging.
Yes, CT scan is mentioned. Useful for diagnosis, looking for those bony changes, but also for ruling out other things on that differential list, and definitely for planning surgery if that's considered. There's a specific CT finding noted too, the halo sign around the oval window, showing the abnormal bone deposition.
So boil it down. Audiometry first and foremost, looking for conductive loss, maybe Carhart's. Tympanometry, stiffness. Then CT scan, halo sign, rule out others, plan surgery.
That's the core investigation pathway outlined in the notes, yes.
Yeah. Brilliant. Okay, we've got the diagnosis nailed down based on your notes. What about management? What are the treatment options described?
So the notes outline two main approaches, medical and surgical.
Okay.
Medical management often starts with hearing aids, usually bilateral if both ears are affected. They don't fix the underlying bone problem, obviously, but they amplify sound to compensate for the loss.
So symptom management.
Exactly. Then the notes mention some medical therapies that try to target the bone metabolism itself. Sodium fluoride is listed, 120 milligrams daily. But, and this is important, your notes clearly state the evidence quality for its effectiveness is low.
Ah, okay. So it's mentioned, but with a caution.
Yes.
Yeah.
And bisphosphonates are mentioned as an alternative if fluoride isn't tolerated, again targeting bone turnover. But hearing aids remain a mainstay of non-surgical management.
Right. And the surgical options.
That's where we try to fix the mechanical problem. The notes describe two main procedures. Stapedectomy, where the fixed stapes footplate is actually removed and replaced with a tiny prosthesis. And the other is stapedotomy, which involves making a small hole, a fenestration, in the fixed footplate and inserting a prosthesis through that. The notes suggest this improves how the inner ear fluid moves and transmits sound.
And how well do these work?
The success rates mentioned in your notes are actually very good, up to 95% elimination of the conductive hearing loss component. Benefits are described as long-lasting, really improving quality of life. But there's a note that if revision surgery is needed, maybe the first one didn't work perfectly or things changed, the success rates are lower.
Okay. High success first time around, less so for revision.
That's the picture, yeah. And the choice between aids and surgery. Your notes imply it depends on things like how bad the hearing loss is, what the patient wants, if they're medically fit for surgery, that kind of thing.
Got it. Aids for symptoms, surgery to fix the mechanics. Good to know the options and success rates from the notes. Maybe think about when you'd lean one way or the other for revision practice.
Good idea.
So what's the long-term outlook? Prognosis. What do your notes say?
Overall, the prognosis described is pretty favorable, especially if surgery is undertaken. Stapedectomy or stapedotomy can lead to significant lasting hearing improvement for many patients. The notes specifically mention that after stapedotomy, the long-term outcome is good. Hearing might still decline naturally with age presbyacusis, but the surgery itself doesn't seem to cause extra deterioration beyond that, which is reassuring.
That's really positive. So treatment often works well and lasts.
According to these notes, yes.
Okay, last section, we always need to consider the potential downsides, complications. What risks are mentioned in your notes?
The notes break this down into surgical complications and what happens if it's left untreated.
Makes sense. Surgical risks first.
The most serious, though thankfully rare, is total unilateral sensorineural hearing loss, complete deafness in the operated ear. Your notes quote a risk of about 1–2%. And that's usually permanent, unfortunately, and doesn't respond to aids.
1 to 2%?
Yeah.
Small, but significant if it happens.
Absolutely. Facial nerve injury is even rarer, like 1 in 1,000. Eardrum perforations can happen during surgery, but the notes say they're usually repairable. More common, but usually temporary, is taste disturbance. The chordotympany nerve, which carries taste sensation, runs right through the middle ear space and can get stretched or bruised.
Ah, the taste nerve. Yeah.
And finally, tinnitus can sometimes start or get worse after surgery in some patients.
Okay, so hearing loss, facial nerve, perforation, taste, tinnitus. That FLAPT mnemonic might actually be useful here. Facial nerve, loss of hearing, eardrum perforation, accidental, taste, tinnitus. Covers the main surgical ones.
That works. And then for untreated progression, the notes say it can lead to quite significant hearing loss, maybe 50–60 dB down. But importantly, they add that complete deafness is uncommon, even if nothing is done.
Good to know. So not usually total deafness if untreated, but significant loss is likely. Important to have those risks on the radar.
Definitely. Thinking about all this, from the genes and maybe viruses
Right.
to the tiny bone getting stuck, the specific tests, and the surgical fixes, it really shows how these complex interactions between our biology and environment can quietly affect something as fundamental as hearing. Makes you wonder about other conditions, doesn't it? Where similar subtle factors might be playing out.
It really does. Great final thought to chew on. And that wraps up our deep dive into your otosclerosis revision notes. We've systematically gone through from A to Z definition, causes, risks, symptoms, tests, treatments, outlook, and those complications. Hopefully, pulling out the key bits like this makes it much clearer for your revision. That's the whole point. Take your material, break it down, make it stick. Turn those notes into active knowledge. Now remember, if you want more fantastic revision resources, just like the notes we've been dissecting today, definitely check out passthemsaa.com. And for loads of great free revision stuff as well, head over to freemsaa.com. Thank you so much for joining us for this deep dive. We really hope breaking down otosclerosis this way helps you nail it in your revision. Bring us your next set of notes soon.